All right, everyone. I'd like to get started if we could for our first round of the year. I'm Andrew Vallejo, stepping in to introduce the first talk of the year. And this is a bit of an introduction. I'm just quickly scanning the faces in the room to see how many may never have heard of the research cluster devotion and how many I'm just preaching to the choir here. So there's a few that probably will learn something. So I would like to start, before we get to the research presentation today, start by introducing what the devotion cluster really is to those that have maybe heard about it and don't know. Tell you a little bit about what we're doing in the next little while. And then we're going to feature speakers who really epitomize some of the work that the cluster is supporting, and we'll hopefully move forward. You'll hear from Maureen and Patricia shortly in that regard. So I'm up here because on the application that went in, John McGaddick and I were listed as co-principal investigators. John's in Toronto, or on his way to it as we speak. Hence, I'm up here speaking to you today. And I really just want to give a very high-level overview of what we mean when we say devotion. At the end of the day, what devotion is an attempt to consolidate what has been extremely effective work in CHRIM and launching two themes. Biology of breathing theme launched around 2002. We still are in existence. And the dream theme, which is now 4 or 5 years old, 4.5, well, coming to 5 years, I think, soon. And the concept here was you have these two highly functional, efficient networks, as it were, clusters within CHRIM, working somewhat siloed, although there was fair interaction on a day-to-day basis between some of us. How do we consolidate that effort and get synergy, create more bang for the buck, and looking for impact? So when Research Manitoba put out its call for cluster applications, it seemed like a natural to try and weave the two, zipper the two together, and come up with an overarching concept. And that's where devotion came to life. And I give John a lot of credit, really, as the person who really got the ball rolling and got this going. And I came on after John's initial initiation of this, or initiation of this. So I'm not going to stand up here and pretend that I was at the front of this from day one by any stretch, but certainly bought in to the concept when it was presented to us. So devotion is an acronym of sorts, developmental origin of chronic diseases in youth network. And our mission really, which you probably can't read, I'm guessing, from where you are, is to reduce the burden and cost of non-communicable diseases in Manitoba, so chronic diseases. That was the call from Research Manitoba. That's what they were looking for. And it was cross-pillar. It had to be research that started with discovery and had a very effective conduit or pipeline to implementation and impact and monitoring effects therein. So evaluating whether we're actually making an effect. So it brings in researchers, basic researchers, it brings in clinicians and clinician scientists, it brings in policymakers, but it also brings in patients, and that's a big part of what we're doing. And as we roll forward with our governance and our capacity to support it, we bring in patient groups, existing patient groups, as advisors to the direction that the cluster should go. So I think the talk today really is a really great example of the kind of work that can be greatly informed by the patients. And I've had some experience in the last year in other ventures with patient engagement, and starting my career as a basic scientist, now doing translational research, actually quite surprised at how significant the input from the patients is in work of my nature, which I would have thought, even frankly, 3 years ago, I wouldn't. What can they tell me about what I'm doing in a wet lab? They actually can tell me a lot if they're willing to listen. So I think I'm really excited about that being a part of what we do. So we have 26 scientists, policymakers, clinicians involved on the application. Message to you today is we will grow and the doors will be open, and you will hear over the next few months as we hire our executive director to run the office, so to speak, how Catalyst grant competitions will be available to bring more people within the network and to launch new initiatives that to help us move forward over 5 years, which is the length of the grant, renewable for, we hope, at least another 5 years at that point. We include some training. We include early childhood educators being trained at Red River College as part of what we're doing in deployment. We collaborate a lot with, we will collaborate a lot with CHI, which is, if we open the windows, we can see through there. Center for Health Innovation Support. So the structure here of the motion is shown. I don't want to go through it in any detail. We have the scientific advisory committee, people we've selected from around the country. I'll tell you in my last slide about our public launch, in which these individuals will be here presenting to us, so you can meet them and understand why we've got them on board to advise us, with John and I at the lead of the cluster, and Terry and ex officio, Terry Clausen, the ex officio member, because really this is nested within CHRIM, and the more you think about it, the labs, the people, the office space, although CHRIM didn't cut us a check for $1 million, their contribution probably exceeds that in kind and just in terms of our ability to do this by an invaluable contribution. So Terry, an ex officio executive lead. We have a steering committee of a number of members who lead these pillars of research within the network: the clinical, the basic, population health, community health. So people like Alan Becker and actually Brandy Wicklow, it says Allison Dart here, but Brandy is going to step in and work with Alan to lead the clinical research pillar, Maureen Dolinsky leading the basic pillar. A lot of that is Adam's models that we capitulate developmental diseases that have developmental origins. Megan Azad, population health, working very closely with Randy Paxu from Center for Healthcare Policy, below, and Rob Santos from Healthy Child Manitoba, working very closely with John actually on the Center for Policy and Community, and that's already paying dividends because we've been invited on Monday to the legislature for 30 minutes to present to the Healthy Child Minister group, and the motion will be front and center, and that was Rob's doing to get us in there. So we haven't published a paper yet, as far as I know, and we're already starting to make some goals with that. So that's really exciting to hear. So we have advisory groups, as I mentioned. We have the executive director and an office, which we will set up here within CHRIM. Very high level, what have we got? What's the cluster pulling together? Unique patient cohorts, at least 3 at the outset. Eye care, which is the kidney cohort, the chronic kidney disease cohort that Allison Dart runs the node here. The child cohort, which Alan Becker has been lead of for many years. And the next gen cohort, which is the type 2 diabetes cohort of pregnancy type 2 diabetes cohort that Randy Wicklow is starting taking over now. So a lot of that will be integrated into work that looks at biomarkers and epigenetic markers. So we'll interface closely with Jim Davies' platform, next generation sequencing platform. Animal models, we have a number within the domain of metabolic disease as well as lung disorders, and those are coming together under one umbrella in the clinical or the basic science pillar. As mentioned, we have our patient stakeholder groups, and we'll leverage a lot of the success that DREAM has had in engaging the First Nations communities in order, as a large part of what we do in that area, but it'll be much broader than that as well. Population health, intervention, we're going to hear today about that kind of work, so I'll leave it for the experts to explain to you some of the ways we can deal with that. And then population-based data linkage. We have a lot of data available to us. Electronic health records are coming, and it's really silly not to consider how to link databases and leverage the information available to us to make an effect. And I think that, frankly, to me, is a very smart way to engage at the level of the policymaker and to actually get changes implemented that makes a difference in healthcare. This one is a bit redundant, I guess. I'm sort of blah blah a bit talked about all of this. So again, it's just, I think what you can take from this infographic is that although it sounds like a lot of stuff that we're doing, we have a very defined mechanism in place, governance-wise, operational-wise, for the integration of these pillars. And that success in one will feed another and inform another, and that's the concept here. We're looking for open, transparent process that can happen. And as I said, we are originally, our initial focus will be on obesity, metabolic disease, and chronic lung diseases, but we are going to open the door quite wide for other disciplines. I know there's probably a place for neurodevelopmental disorders in the network, and I would, don't quote me on this, but casual conversation says within a couple of years we would anticipate calls for small catalyst grants to bring that kind of expertise in the room. I see Mark sitting at the back there, so we are looking to broaden our scope over time, but starting focus, getting it right, so that when we do that, it will be done effectively. Data management, evidence-based implementation. So the last thing I'll say before I let the scientists give their talk today is that we have a public launch planned, and it'll be in this room, and it's the day after Child Health Research Day. So our scientific advisory board members are coming in on the Thursday. We'll all be sat at a table at the Child Health Research Day dinner the night before, and they'll get a chance to meet the people involved with devotion. So Larry Lands from McGill, he's a pediatric respirologist I know quite well. Gary Lacasse, who's known to many here. I've not met Terry before myself, and Sanford Davidge from the University of Alberta will all come in, and they are the core of our scientific board. There's a couple of others who can't make it, but they'll give presentations. The intention of this day will be who are they, what are they bringing to the table, how do we engage them, so that devotion members will get to know the expertise they can bring. And this is open to the public. This, we would like to engage people, even if they're not part of the cluster, to get a sense of how we operate and do things. And the pillar leads from within devotion are going to give their vision of what we are doing and where we're going on that day. So you'll hear from Brandy and Alan, Megan and Randy and Rob Santos, and I suspect it'd be difficult to go through a half a day without John and I getting up and saying something, given that our penchant to speak too much. So I think I'll stop there. I would, if there are other burning questions that people think others would like to hear the answers to, if there's questions you have and you want to ask me after, I'm happy to answer. But anybody have a question? Clear? Good. So I am going to let Maureen, who's up first? Is it Maureen? So I'm going to let Maureen and Patricia introduce themselves. One slide ahead. And anyway, so I'd like to introduce Maureen Heaman, Faculty of Nursing, to take us into the talk today. Maureen. Oh, can I say one more thing?
Sure, absolutely.
Just FYI, we haven't confirmed it precisely yet, but devotion has, I think we've agreed, and we'll take on the responsibility of bringing in one speaker roughly a month to fill the CHRIM slot. So you will see regular devotion branded CHRIM rounds through the year, and that's we have a meeting, I think Monday or something, to finalize that, but roughly once a month. So you're going to see the magnificence of devotion science on a regular basis, but people pick the best to go first.
Thanks, Andrew. Well, we're very pleased to be here today. I'm Maureen Heaman. I'm a professor in the College of Nursing. I do have a scientist appointment with CHRIM and also with Manitoba Centre for Health Policy. And my colleague here, Dr. Patricia Gregory, who is at Red River College, and I have the coordinator of research and scholarship in the Department of Nursing. And I'll explain what Pat's role is going to be in a moment. I've been working on prenatal research for quite several years now. It's been the focus of my program of research. And John McGavick and Rob Santos approached me when they were forming devotion, and they got the funding, and what they were looking was what they called shovel-ready projects that they could get going so that there'd be some quick kind of results coming out of devotion and get some things off the ground rather quickly. And so that's really why I'm here today, at least that's my understanding, and Pat, is to give you a bit of the background of what this is and then what the project is that's going to be funded through the Devotion Cluster Grant that we're doing. So hopefully, and we were asked to speak for about half an hour, so I think we've got a good bit of time, and then we'll have some time for questions. This isn't a thorough research presentation because I thought we were limited in time, so I'll have to come back another time when I have the final results of some of the work I'm doing right now. So, whoops. So what we're going to do today is we're going to talk about the results of a couple of my other studies, the factors associated with inadequate prenatal care among inner city women in Winnipeg, how the results of that were used in developing the Partners in Inner City Integrated Prenatal Care Project, and what PIPC consists of, and some of the preliminary evaluation results. And what the plan is through the devotion funding is to conduct a replication of the factor study in the Northern Health region. So that's really what we're leading up to with this. And it's partly come out of Rob Santos and Jan Sanderson have been quite involved in our PIPC initiative, and also Karen Hurd, who's the Deputy Minister of Health, and Avis Gray, her Assistant Deputy Minister, have been very supportive of what we've been doing, and they were quite interested in trying to move some of this into the north as well, and I'll show you why in a minute. So, okay, so why are we talking about prenatal care? We're here in the Children's Health Research Institute, but really, it starts early. If you start when the baby's born, it's too late. We really need to intervene, preferably preconception, but it's really hard to get into those, get access to those women. So if we can start prenatally, we have some hope of making a difference and affecting the developmental origins of disease and hopefully improving outcomes. So it's very important to start prenatally. And just taking you back to what the Chief Public Health Officer of Canada said in their report in 2009 about how ongoing prenatal care is important to achieving a healthy pregnancy and birth and positively influencing the health of the child in the early years. So that's really why we're interested in prenatal care. My own interest in it came when I was doing my dissertation way back when, and I was really at that point in time looking at risk factors for preterm birth in Aboriginal and non-Aboriginal women in Manitoba. And out of that, it came that there were probably only about 3 significant modifiable risk factors that I found in that study. One of them was inadequate prenatal care. And that was kind of when I switched the direction of my program of research and decided it was much easier to focus on trying to improve access to prenatal care than solve the whole issue of what causes and prevents preterm birth. So I kind of did a 100-degree turn there. The Canadian Maternity Experiences Survey that I played a part in planning did show that Manitoba is not doing so well in the area of prenatal care. We had the highest proportion of women who reported not getting prenatal care as early as they wanted among the provinces, and we had the second highest proportion of women who initiated prenatal care after the first trimester. So why should we be concerned about prenatal care? And does it really make a difference? It's probably easier for me to read off of this. So we do have a universal health care system, and because of that, women theoretically all have access to prenatal care. Everybody should be getting good prenatal care. But when I started delving into this and looking at prenatal care, I've done a couple studies, an older one, and then we kind of did a redo of it more recently. But what we find is that not all women in Manitoba get good prenatal care, and there really is differences in rates of inadequate prenatal care across the province. So what we found that some of the predictors of inadequate prenatal care, looking at 68,132 women giving birth, were things like young maternal age, being a lone parent, living in a low income area, being on social assistance, having 4 or more previous births, and smoking alcohol and drug use. And inadequate prenatal care was associated with a variety of adverse outcomes. So therefore we should be concerned about it. This is only association study, not cause and effect, but what we did show was that inadequate prenatal care was associated with higher odds of having a stillbirth, a preterm birth, a low birth weight infant, or an NICU admission, higher odds of maternal postpartum anxiety and depression, and also lower odds of breastfeeding initiation, and lower odds of having the baby immunized by age 1. So it shows that there may be some, and this was after adjusting for region of residence, income quintile, maternal age group, parity, and medical obstetrical complications, including diabetes and hypertension. So it's showing that there is an association. This shows the diversity in rates of inadequate prenatal care across the province, with the red areas being areas with rates of greater than 40% of women having inadequate prenatal care. So you can see that the north in particular has high rates. The inner city areas in Winnipeg also have high rates, although not quite as high as the north. This is some data from the Perinatal Services and Outcomes deliverable report that I was the PI on for the Manitoba Centre of Health Policy, showing that rates of inadequate prenatal care by what were then the RHA groupings shows that, again, Norman and Burntwood have very high rates of inadequate prenatal care compared to other areas of the province. And similarly, in inner city Winnipeg, you can see that Inkster downtown and Point Douglas have significantly higher rates compared to the Winnipeg average. And the suburbs, the rate is all less than 5%. But then you're getting up close to 20% in some of the inner city areas. So building on that kind of research that I did...
Can I just ask a
question?
How are you defining adequate prenatal care if alcohol, drug, and smoking, for example, are simply markers rather than part of it? So what is your definition?
Good question, and I should have done that. So I tend to do this so often, I make assumptions. So inadequate prenatal care was defined based on either a late initiation of care after the first trimester, a low number of visits in relationship to what is the expected number of visits for that gestational age at delivery. So if you have less than 4 prenatal visits overall, or you start prenatal care in the second trimester, for sure you fall into inadequate prenatal care. There is other gradations of that. So it's really based on what they call the prenatal care utilization indexes. So it's simply a measure of quantity. It does not measure the quality of prenatal care. We have developed an instrument more recently that measures quality prenatal care, but they haven't been used in any of these administrative data studies as of yet.
Okay, so you could visit a lot but still be malnourished.
That's right. I mean, I'm not saying anything about what prenatal care does. We're kind of assuming that if you go for prenatal care, there's some good to be found in it. It's really a measure of use, access to and use of prenatal care. Does that help?
Yeah.
Okay. So knowing that then that women in the inner city Winnipeg had inadequate prenatal care and that we had easier access to do a study in the city rather than doing the whole province at once, we proceeded with doing a study where we looked at what were the factors associated with inadequate prenatal care in the inner city. We felt we could not proceed with an intervention study until we had a better understanding of what were the barriers, the facilitators, and the motivators to prenatal care. So we were funded by CIHR. I formed a team of decision makers and researchers, including Mike Moffat, Lawrence Elliott, and Michael Halwa, who some of you may know, along with decision makers Linda Jaden, Pat Gregory, and Catherine Cook. And we did a study including a case control component of women with inadequate and adequate prenatal care and a qualitative component of interviews. And these are some of the characteristics of the women in the two groups, which will become relevant later. Then I'll just try and find that. So you can see if you look through the percentages comparing inadequate prenatal care to women with adequate, that women who had inadequate prenatal care had higher proportions of being single. First Nations, 73.5% of the women in our inadequate prenatal care group were First Nations. Even though they came from, I should explain that they all came from the inner city, but even though they all came from the inner city, the ones in the inadequate prenatal care had an even higher proportion of women in a low-income category. 78% of them smoked, which is really high. 39% reported using illicit drugs, 15.5% reported being abused during pregnancy. Most of them had an unplanned or were unhappy about their pregnancy. Many of them didn't have a regular health care provider, and somewhat of a surprise to me at the time was that there were 30 women in our inadequate prenatal care group that didn't get any prenatal care at all, which, given the world we live in, I think is somewhat appalling.
And what about alcohol?
Alcohol?
Not mentioned there.
No, just due to space, but it was higher as well. Yeah, and I did illicit drug use, but alcohol was higher too. So then we asked about barriers and facilitators, and so some of the barriers that we found that we then worked on when we did our intervention studies were things like not knowing where to get prenatal care or not being able to get an appointment, problems with transportation or childcare. This was a big one. Hours at the clinic weren't convenient, or they had to wait a long time for their appointment. Many of the women reported not seeing a perceived need or value in getting prenatal care. They either had the attitude that they could take care of themselves during pregnancy, or they would just simply get advice from family and friends, particularly if they had had previous children. Family problems and personal problems were a big issue. They reported being under stress, being depressed, moving a lot, worried about, this is another big one, worried about the baby being apprehended by Child and Family Services. So they would avoid going for prenatal care, or if they were thinking about having an abortion until they got that issue resolved, they wouldn't report for prenatal care. But interestingly, I mean, we looked at a number of motivators, but women in both groups, the adequate and the inadequate care, over 90% of women in both groups said they were motivated to have a healthy baby. So sometimes it was their personal circumstances that prevented them from seeking prenatal care. So in the qualitative component, we also asked for suggestions for improving prenatal care. So women said things like having prenatal care closer to where they live, easier to get at, providing transportation to prenatal care, having tangible rewards for showing up, and individualized care and respectful, non-judgmental caregivers. From healthcare providers, things like establishing community-based prenatal care clinics, increasing the public awareness of prenatal care, because many women didn't really seem to understand the benefit of it or where to go get it. Expanding midwifery services, having drop-in elements, and multidisciplinary one-stop shops. So we have published the results of the barriers study, which has more information, and also the qualitative study, the findings from the healthcare providers, and the one of the qualitative women's findings is under review at the moment. So then we took all those findings and we convened a knowledge translation workshop funded by CIHR and brought together over 70 participants and did some brainstorming about what we could do with the results and what kind of interventions might make a difference. We formed a steering committee that then went on with some of our core members and additional people. Or the key midwife at Mount Carmel Clinic. We'd get these women in quickly, we'd see them, we wouldn't make them wait for an appointment, we'd try and get as much done at one appointment as we could, fetal assessment, all the lab work, etc., in case they didn't show back up again, at least we'd have some baseline information. And we relied heavily on what we called enablers and incentives, and the enablers were bus passes and taxi vouchers, and these did make a big difference in women showing up for their appointment. We also had a social marketing initiative to address the issue I identified earlier of women not valuing prenatal care, recognizing the importance of it, or knowing where to go. So we did a variety of things there. I don't have time to tell you about all that. Evaluation strategies, we will be going into the population level evaluation soon. We're waiting for the data for up to the current year to come into Manitoba Centre for Health Policy, and then we will have a look at that bar chart again and see if we made a difference in the rates of inadequate prenatal care. We're also going to look at some of the outcomes. We've been doing the mixed methods approach where participants in PIPC undergo a questionnaire. We're reviewing health records, and we're also doing interviews with both women and providers. And we've redone our chart review of women presenting to women with no prenatal care. These are some photos of women in the project, a couple of the midwives, one of the midwives here, whoops. Wow, that's touchy. And so anyway, some of the women. And this just shows we enrolled over the time frame of the study 281 unique women. Interestingly, 18 of them were repeat clients. They liked the program, so they actually showed back up in a subsequent pregnancy in our 3-year time period. It is difficult to get these women to consent because they're a little bit distrustful of the healthcare system in some aspects. So 219 agreed to the chart review. We've completed more than 135 now, but I have some preliminary results based on 135. We did 89 interviews. This was as of June, so we've done more there, and 22 qualitative interviews with women and 26 with healthcare providers. So I just have preliminary results at this point in time. But what the preliminary evaluation seems to show us is that we are reaching women who were appropriate for the project and at risk of inadequate prenatal care. We found that the PIPC clients had earlier initiation of prenatal care and more prenatal visits compared to a comparison group of the women that were the cases or the women with inadequate prenatal care in the previous factors study. They were getting better integration of care. The providers were talking to each other, sharing information. We were linking them to other services like social work and child and family services. And we did find, although this was not one of my objectives because I wasn't quite sure, we wanted to increase access to and use of care, but we did find that they were having improved pregnancy outcomes in terms of reduced rates of preterm birth and low birth weight infants and potential for fewer infant apprehensions. The staff involved with the program are telling us that by working earlier with the families and child and family services and social work, we're able to keep more of the babies with the family or a more controlled apprehension where they might go to a family member. And Pat can probably address questions related to that better than I can. So just quickly to run through some of the chart review results. Women primarily came from Point Douglas and downtown. They ranged in age from 16 to 40. The majority of them are single. 73% of them had less than a high school education. The majority of them were either First Nations or Métis. 10 of them said they were homeless. The staff reported a lot of couch surfing going on among the women in the program. 61% were on social assistance, and we did help women apply for the prenatal benefit that's offered. So that was a good thing. They had a mix of caregivers, often shared care model, but the midwives at Mount Carmel and the obstetricians and a family physician at Women's were quite involved in the program. 81 of them had CFS involvement. 45 of them had had a previous apprehension. 11 of the infants had signs of drug withdrawal and a discharge outcome. 94 infants went home with the mother, 35 were apprehended, and 3 were relinquished. And breastfeeding initiation was not bad, 69%, given the characteristics of the group. So when we compare the women that were in the PIPC study to the women with inadequate prenatal care in the previous factors group, you can see the characteristics are similar, if not even worse in some instances. So similar rates of education less than high school being First Nations or Métis, high parity. The smoking rate was slightly lower. This is based on the chart review, and the drug use during pregnancy was slightly lower, but sometimes it's hard to identify those from the chart clearly. But you can see that the number of visits did increase. I have to look into why 3 got none. They might have been referred through the street outreach van and then actually maybe didn't show up even though they were stamped as being a PIPC client. So, but you can see that more of them, 50% were getting at least 5 to 9 visits that were in PIPC, and 18.5 got 10 or more visits. The preterm birth rate, if we look at the cases in the factor study, was 14.4%. In our PIPC clients, it was 10.4 based on the chart review. The provincial rate is about between 7 and 8%. So it's still higher, but it is better than a comparable group. If we look at the PIPC clients that were multiparous, which in essence means you become your own control group, we thought we'd have a look at that. So 90 of the PIPC clients had had previous pregnancies, so we looked at the immediate prior non-PIPC pregnancy as a comparator. And you can see again that the number of visits were increased in the PIPC clients, as well as fetal assessment unit visits. Preterm birth rate in the previous pregnancy was 17.8% and 12.2% in the current pregnancy. And I think this is somewhat encouraging because we know that having a previous preterm birth is one of the biggest risk factors for a subsequent preterm birth. The low birth weight rate also decreased in the women with PIPC pregnancy. This is not a cause and effect study, but it is showing, using women as their own controls and looking at their previous pregnancy. It seems to suggest we are improving the outcomes. This is not a true comparison, but I raise it up to you to show what happens if women have no prenatal care. So we did a study, Dr. Maggie Morris supervised a BSc Med student in doing a study of women who reported to the triage unit at Women's Hospital that had no prenatal care. And in that study, there were 109 women. This was just prior to us starting the PIPSI project. And we're comparing to the PIPSI clients. But you can see if women have no prenatal care, that their outcomes are not very good. The preterm birth rate, 34%. High rates of both small and large for gestational age, high rates of admission to the nursery, and in fact, there were 2 stillbirths and 1 neonatal death, which are really high rates when you consider there's only 109 women in that group. So if we move over to the PIPSI clients, we see that our preterm birth rate looks a little better, and more of the women are involved with child and family services, 63.8%, but the apprehension rate is lower. So there are benefits, I think, of getting them involved with child and family services. Again, the PIPSI clients are not totally the group that have no prenatal care. PIPSI clients, we're trying to target women with inadequate prenatal care, but you can see some of their characteristics are still somewhat similar. So these are, I've only presented a little bit of the data. I didn't take time to go through any of the data from the questionnaires or the qualitative data. Another time, maybe I can come back and do that. I'd like to acknowledge the members of the research team, all of our working groups. We had probably more than 50 people involved in organizing and implementing the project. We are planning to keep it going, even though the evaluation piece has finished. There's been some talk of moving it out to the city as a whole. We decided we could still call it PIPSI, so instead of Partners in Inner City Integrated Prenatal Care, we'll just call it Partners in Integrated Prenatal Care, so we don't have to change all our social marketing materials and pamphlets and things that we have developed. And we did get some funding from WRHA, which is apparently hard to do these days, to keep the coordinator role for the rest of this fiscal year, and we're seeking funding to sustain it following the fiscal year. So I'm going to turn it over to Pat now, and Pat is going to be the PI on the Northern replication study, and I'll be co-PI because I'm hoping to move to a reduced appointment in January, and I did not have time to do all this, but Pat has been involved through both the factor study and the PIPSI study, and we're looking forward to working together.
So you can see why there's a lot of interest in something called PIPSI North. But before we get to PIPSI North, probably we need to replicate the factor study so we can understand a little bit more about those barriers, facilitators, and motivators. They might be quite different in the North. Certainly, we saw the slide from Maureen. The rates of inadequate prenatal care are pretty high in the North. So we need to replicate this study. The study will be an important precursor to our PIPSI North project that we're hoping to get to eventually. So we need to take a look at the study, and we need to adapt it, of course, for the North. So we're in the process of doing that right now. So we put together an advisory and a research team, and we're still in the process of finalizing our advisory team. We've reached out to some stakeholders that haven't responded yet, and we're still working with them. But we have Dr. John McGavick and Dr. Rob Santos as part of our advisory committee. The Northern Regional Health Authority is really excited about this project. So excited that they've put a board member on, and the CEO is part of our advisory committee, and it fits really well with their strategic direction. So lots of momentum around this type of study. We have the chief medical officer on our team, and he's also an obstetrician, so that works well. We have the medical director for the primary care clinics in the North, the executive directors of clinical services. We have a representative from First Nations and Inuit Health Branch. We have representatives from Northern Medical Unit, as well as the health director from the provincial nursing stations, and representatives from Manitoba Health and Healthy Living and Seniors. So a broad group of stakeholders that hopefully will guide our study. Our research team is made up of myself and Maureen, Dr. Michael Moffat, the medical officer of health from the Northern Health Region, the director of public health in the Northern Health region, the executive director for clinical services, the director for primary care, as well as representatives from First Nations Health and Social Secretariat of Manitoba, the Assembly of Manitoba Chiefs, and representatives from the Manitoba Health and Healthy Living Council. So a big group, and they've been starting to give us guidance on how to adapt this study to the north already. So our focus really is to replicate the study, so it's about identifying those barriers, facilitators, and motivators among women in the north. We're going to use a similar design. We're going to use the mixed methods with a case control component. Our budget is a lot smaller than Maureen's budget that she had for doing this study in Winnipeg, so our sample size will be much lower. We're thinking about 200 women, 100 cases of inadequate prenatal care matched with 100 controls with adequate prenatal care. We're also going to do the qualitative component, again with a smaller sample, about 12 women and about 12 healthcare providers, so that we can learn more about the various facilitators and motivators. So I'll be the PI, as Maureen had mentioned. We're going to hire a part-time research coordinator who will be located in Thompson, along with a research nurse who will be able to recruit and collect data in the PA and Flin Flon and travel between them. So we're going to, again, recruit women in the postpartum period from 3 of the main delivery sites in the Northern Health region, and that will be the Thompson General Hospital that has anywhere from 1,000 to 1,100 births per year. The hospital in the PA, St. Anthony's General Hospital, with about 300 births per year and about 150 births coming out of Flin Flon. So our research coordinator will collect data in Thompson and will coordinate the study as well. And then we'll probably have a casual research nurse that will attend to the births as they occur in the PA and Flin Flon and travel between those 2 sites. We're going to interview women using a structured questionnaire that we're currently in the process of adapting for the North and making sure that it's appropriate. The qualitative component, as I mentioned, we're going to be using a semi-structured review guide, similar to that was used in Maureen's study, but again modified. We're also going to interview the healthcare providers, and we're also going to ask them about what their ideas are for health system improvement in the North. So we're going to use purposive and maximum variation sampling strategies to be able to get lots of diversity among the women and the healthcare providers. We have an aggressive timeline. As I mentioned, our budget is limited, so we're going to try and get this done in a year, but it is an aggressive timeline. In October, we're hoping by October to finalize our instruments and our methods and our recruitment strategies and make sure that they're going to work in the North. And by November, hopefully we'll have our ethics submission in, our access applications to both the Northern Regional Health Authority and First Nations and Inuit Health. We'll be doing our presentation to AMC HERG to keep them informed of our progress and what we're planning to do. In December, hopefully we will have all our approvals. We can proceed to hiring and training and informing stakeholders and staff in the North about the study and what it means. And data collection, hopefully between January and June, but that is aggressive. Try to collect all our data and then start our data analysis, hopefully into September, complete that, and proceed with some dissemination of the findings and some knowledge translation activities that will hopefully lead to PIPC North and wrap up our project in December. So that's a quick overview of what we want to do in the North. But any questions for Maureen and Mike?
Hi. Have you considered looking at the women delivering at CMD and women's? Because there's a lot of women from up north that just deliver in the city.
Right.
It would be a lot cheaper, probably.
It would be a lot cheaper. The Northern Regional Health Authority has jurisdiction over the PA, Thompson, and Flin Flon, and so if they're going to be looking at systems change, they can actually make that, they can have the ability to make that change. Whereas the women who are coming from other northern communities, nursing stations, like Missouri, Island Lakes, etc., are coming down to Winnipeg for delivery, but there's no ability really to alter, to do a health system improvement in those communities. Now, We will try to.
Under
look-
the control.
Under the control of the Northern Regional
No,
Health
of course,
Authority.
It's
I mean,
under-
the federal nursing stations are
Yeah.
involved too, right?
So we're hoping to be able to look, we're going to ask women, you know, what communities they're from and whether they receive their care from a nursing station or a provincial nursing station. And hopefully we'll be able to generate some data. We'll have to see what the sample size looks like, but hopefully we'll be able to generate some of that kind of data that we can feed back to organizations like FNIP who are providing services in those communities to learn more about that. But the focus is really on the Northern Regional Health Authority. So we'll get women from those communities delivering in the north. But yeah, we haven't looked at women.
Ideally, we would do both. You know, that was my thinking. We could go to St. B because I used to work there and I know we get lots of women from Island Lake and different areas there, and we could have done the case control. But the CEO and other people at our first meeting said, well, that wasn't really the direction they saw the study going. And given our limited budget, we decided we would work collaboratively with the Northern Health Region as our main partner and meet their needs, and then certainly there may be a future opportunity, or if we can find some additional funding to work with FNIP and
Right.
the city.
Might be another study. Yeah.
Another study, possibly, yeah.
Thank you very much for the lovely presentation, and I applaud your ambition and scope. The pediatrician in me applauds your ambition and scope, but on Thursday I wear my curmudgeonly statistician hat, and I just wonder, for instance, you cited an improvement in prematurity from 14% to 10%, which has a p-value of 0.1 associated with it. So what kind of effect sizes are you really powered to see with this 100 cases?
We didn't, it's not powered, see, that's the thing, when we set up the study and we did the power analysis and whatnot, we were looking at improving access to and use of prenatal care. So that's really our primary outcome that the study was designed to answer. And you're right, from a statistical point of view, that's what we're prepared to look at. But the outcomes show a trend, at least. I mean, you know, it's hard to put a statistical a lot of weight in them, but they definitely do show a trend. And it'll be interesting to see what the population health analysis shows at the Manitoba Center for Health Policy. But, you know, we certainly didn't get all the pregnant women in those three regions, right? The three, downtown, Inkster, and Point Douglas. So I'm not sure what to expect of those findings. So we will know more then, and I can come back and present. But, I mean, you know, it's a good thing, I guess from my perspective, starting the PIPSI project, it's a good thing in and of itself to get women into prenatal care. Preterm birth is not the only outcome we would look at, and we've talked about the fact that there's other things that should be considered. But if you're, you know, maybe you have some benefits in increasing breastfeeding rates. By getting women linked into care, they might be more likely to seek well baby care and get their infant immunized and have a relationship with a care provider that they trust. You know, maybe better nutrition, getting them some food. I mean, women would show up to their prenatal care visit at 2 in the afternoon. They hadn't eaten all day, and one of the things we provided at Women's was we would get them food. You know, so how much of a difference we made with that. We also referred them into lots of other resources. So there's all those kind of things that's a little bit hard to measure. We have qualitative data about the benefits of the project. But yeah, your point is well taken. Thank you.
Maureen?
Yes.
Any reason why it looked like in the immigrant families that were living in that area, in the downtown area, they seem to have fewer cases of inadequate care? What's the difference between, you know, people in that area?
Pat can maybe help me answer this, but I mean, I was curious about that because I did a systematic review looking at immigrants' women's use of prenatal care, and they were higher users of inadequate care. But what the immigrants are, they seem to be motivated to get care. So if they come in and then they're helped to get access to the resources, they do go for care. So they don't seem to be our problem area in Winnipeg, which is interesting. And there is one of the Healthy Start for Mom and Me groups that's specifically geared to immigrant women, and they get quite a good turnout. I don't know, Pat, do you have any other thoughts?
Just from my...
So do they seek it, is what I'm saying?
Yeah, they tend, from my anecdotal experience, working in women's, they come and seek out care.
Yeah, so they're not our target group really. So it's interesting to look, I didn't say that, but it's interesting to look at that data, yeah.
In the PIPSI part, how many people did you have to approach to get that many women in your study? Do you have a sense of that, or were you not able to collect?
No, we took them as they came, right? So it's not like you can go out, we felt it's not feasible to do a randomized controlled trial. For one thing, you can't randomize people to no care, lots of care, right? It's not ethical. But also, this is a very hard to reach population, so we just had different ways of finding them. I mean, it's interesting how it worked out, and groups that were interested, Lisa and Kelly ended up doing presentations at the Corrections Institute because they wanted to hear more about the project and referred women that were being let out of jail to the project.
And as community health organizations or community organizations found out about us, they would hook women up to us, Sage House, for example.
We do have data from the perinatal services report that I can go back, and I need to look at that, of the women, the number of women in those communities that had inadequate prenatal care. And I do have those numbers somewhere, but they're not retained in my head. We didn't get them all, that's for sure, because they're still hiding out there somewhere and we haven't found them.
Maureen, I had a question about the data that you had, and some of the things that you noticed made a huge difference, like giving bus tickets or bus passes. Are you doing anything with advocacy or developing any programs to address that? I know, like, I'm a transition coordinator here, and we have clients that can't even afford bus tickets.
Yeah. Well, we're hoping to get ongoing funding. We've done a presentation to Aboriginal Issues Committee of Cabinet and Child Committee of Cabinet and WRHA Board, and it was well received in all those places, and we got the kind of interim funding to the end of the fiscal year. Part of our funding request is to be able to continue to provide the bus tickets and the taxi slips because they're essential. I mean,
It's a much bigger kind of.
Well, it is. I mean, yeah. Personally, I think all women, when they're found out to be pregnant, they should get a bus pass for the duration of their pregnancy. That's what I would do. But
When they schedule prenatal assessments at 7:30 in the morning.
yeah. Yes.
And it takes them 2.5 hours.
Yes. And Maggie Morris, she used to work, she runs the adolescent pregnancy clinic. I mean, they never show up in the morning. So actually, in looking at the hours of the PIPC coordinator, we were thinking of having her work at a bit of a later day because they tend to show up more in the afternoon and don't come in the morning. Some of them anyway.
And with the PIPC clients at Women's, we took them when they came. They don't show up on the day, they show up the next day, they show up in the afternoon, 4 o'clock.
But the transportation issue is often the main reason.
Yeah.
So
So
lack of will.
No, it's not always lack of will. It's living in poverty, having 3 other little kids that you have to drag along with you to the appointment, and bus in the winter. So that's an issue. Now the midwives work out well too because Mount Carmel Clinic is a convenient place, or if they see them at the healthy baby sites, that's convenient. Or the midwives will do home visits for some of the prenatal care as well. So then the transportation issue is alleviated a little bit. So it's just a case of really being flexible and innovative and having a will, I think, to do this. It's one at the
I
back
was going to
there.
ask, seems like a really great program. I assume it's safe to say that these women, most of them don't have any connection with healthcare prior to the pregnancy type thing. Is there any sort of similar program or anything that you've ever heard that would try to target these at-risk women before pregnancy type thing? And I don't know, youth drop-in centers, or so birth control, things like that could be more encouraged, because also the high percentage of the women being unhappy with pregnancy. So
Yes,
it
it
seems
has
like
implications, doesn't it?
Well, there's different programs around the city for sure, like Women's Health Clinic and the free birth control program. There's programs in the high schools now, some of the high schools. Mount Carmel Clinic. I mean, there's lots of community-based kinds of services, but do they reach everybody?
Yeah.
That's the challenge, right?
It's sometimes easier to reach them when they're pregnant, right? Because they're a little bit more motivated to seek out services, but you saw that stat that a lot of them didn't have a regular healthcare provider. So if you can link them into care, then at least maybe the next pregnancy will be more planned and better spaced. Yeah.
Okay, good.
I think Graham's
Okay, yeah, so Pat, I was just wondering, I mean, on that list of people that you're going to have collaborating, I noticed that CFS isn't on there. Do you think that it might be wise to have an advisor or representative? from
That's
CFS?
actually a good idea. We'll have to
Health staff.
investigate. Yeah, we'll talk to the Northern Health Region, but that's an excellent idea. Great.
I was very intrigued actually about your comment that there was a sort of fear of CFS, and I was curious, you have a very large number of multiparous women. Is that fear, and you probably didn't study this, but do you have a sense, was that fear based on previous bad experiences or just a general community anxiety?
No, I think it's based on previous bad experiences or they're using drugs and so they don't want their drug use to be identified so they don't show up for prenatal care. The philosophy underlying PIPSI is a harm reduction approach and a trauma-informed approach. We're working with a high First Nations population. We have to be aware of all the, residential school and other issues there. And it's to be non-judgmental and accept women where they're at and try and work collaboratively with social work and CFS. And so I think it's working to some extent, right?